This Medical Main Street event focused on artificial intelligence and healthcare. We're pleased to have a packed house for this important discussion on technologies in healthcare that are impacting our lives in ways we never dreamed possible. I attended a Tech 248 event last week that demystified artificial intelligence, but unfortunately I'm still mystified. It didn't quite demystify me completely with that. A special thanks to our panelists, some of whom have joined us from Atlanta and Boston and around the region. Welcome. Medical Main Street is helping companies navigate the many technological and social forces, including the emergence of artificial intelligence, that are changing the healthcare landscape. AI is creating opportunities, however, in such areas as expanding access to care in underserved communities, turning the electronic health record into a reliable risk predictor, and aiding clinical decision-making at the bedside. These innovations and others will provide unique opportunities for this region to leverage its strengths, capabilities, and competitive advantages in pursuit of economic growth for Oakland County. The health and life science sector in Oakland County is our first standalone billion-dollar emerging sector program. You heard Dom say we just this month reached $5 billion in new investment in emerging technologies. That's our main strategic focus, is to help diversify the makeup of Oakland County, so we're not relying on any one industry. And Medical Main Street has definitely helped us reach that milestone. Capital investment in Medical Main Street since 2004 totaled $1.26 billion. These are companies that have located or expanded in our community. 66 companies creating 8,600 new jobs. That's great information. And it's really due to the investment, the businesses that invest in our community, our staff, our partners. We can't do this alone. Medical Main Street activity in the health and life science represents 26% of capital investment across all of our 10 emerging sectors. Now I'm happy to turn it over to our moderator and good friend, Kevin Lasseter, sorry. Who am I thinking of? Lasseter. Kevin Lasser, founder and CEO of GEMS Technology and a great ambassador for Medical Main Street.
Well, thank you. Everybody sit, please. These great panelists, please sit up. Everybody, those seats are for the panelists. Thank you. So, Brooks Patterson is not here physically, but he is here. So about 20 years ago, he came up with a thought. It was called Automation Alley. It wasn't a building at the time. It was basically set up to help businesses in Oakland County and the people in Oakland County get technology skills. But what you're looking at 20 years later is this amazing facility with some terrific people that work here. 15 years ago, he had an idea called Medical Main Street. Medical Main Street was an idea that Brooks had that would get healthcare professionals, medical people, small companies with large hospitals so that they could share ideas. So what you're seeing here is two amazing ideas. And you know, if you have one idea that turns into this, that's spectacular. I'm sure there's hundreds of ideas that Brooks has had. Another one is the Rainbow Connection that George Miller is running. It's our corporate charity. It's amazing what they're doing for children. So Brooks isn't here, but he sort of is here. So we're here, this amazing group of people, to talk about artificial intelligence in healthcare. So when I think about that, is everybody familiar with the bell-shaped curve? If it's for me, I'm not here. Is everybody familiar with the bell-shaped curve and what it looks like? So when you look at a bell-shaped curve, you have your early adopters, about 17%. Then you have the middle, the big part of the curve, and then you have the end, the late adopters. Well, you're here. You're an early adopter. So give yourself a hand for being an early adopter. Now, there are pioneers to this, too. Those are the first people in. So I had an amazing day yesterday. We met with Henry Ford Village, which is onboarding some artificial intelligence through Dan's technology. We met with a terrific young lady, and we said, you know, what is this going to do? Now, this is Heather over there who takes care of the people. And she said, you know, I'm not excited about this. I don't really know about the technology, but I'm going to tell you something. The families of my patients are very excited about this. Thank you for sharing that, Heather. It really was impactful. We talked about it at dinner. I also had a great dinner. We had a great dinner with Sandy Sparrow. He is, everybody familiar with telehealth? Those robots in telehealth that are in 2,000 hospitals? Sandy was a very, very big part of that. And to see people like Heather and Sandy involved in something like this is really good for us as patients and for our family. So the people to my left are certainly pioneers. And when you put a panel together like this, you try to do your best. You have education research, which is Gloria. You have doctors, Dr. Carter, John Byrne, CEO of Home Health. You have the technologists, Dan and Jim. Now, we don't have legal, but I have to tell you how important legal is here, okay? Everything that's going to be talked about today has legal ramifications, and we have terrific people from Butzel Long, Bob Schwartz, and Deb Giroux. Deb, she didn't register. That's why her name is written on her tag. But if you have any questions, we know we go to them when it comes to technology and healthcare, so please ask them. So I know you're not here for me, and I know that because I got about 28 text messages, I can't tell you from whom, that said, Kevin, these people aren't here to hear from you. Sincerely, Susie Vestovich. So thank you for that, Susie. So based on that, I'm going to introduce you to these amazing people. Dan Pompilio is the Chief Executive Officer and founder of Simple C. He came from Atlanta for this event. I think the coolest thing about Dan is and everybody on this panel is just very modest. And Dan started Simple C 10 years ago because his dad had early stage dementia. And he said, there's got to be something to help my dad. And today there's thousands of people using his technology. So he also started a small company, I don't know if you ever heard about it, called WebMD. Dan started WebMD with some other partners. So it's an honor to have you here, Dan. And fun fact about Dan. Dan's very, very generous and charitable. He is so generous that if you ask him for 5 minutes of his time, he'll give you an hour and a half, whether you need it or not. So, Jim Winder from New Jersey. He works for a great company called PTC. They're an IoT, they're the leader, the world leader. We went to their conference in Boston. It's amazing what they're doing. Jim has a great background in technology. They've trusted him with some key accounts, including Medtronic. So Jim, thank you for being here. Fun fact about Jim is he has seen every Seinfeld episode at least 20 times. Is that true? Close?
Maybe.
Close, okay. So we have Gloria Jen, with SRI, Stanford Research Institute. So actually, Stanford Research Institute, they basically invented Siri. So Jen runs, I can call you your first name, can I? Yeah. Okay, thanks. So Gloria runs Stanford Research Institute in Michigan. We've done some research studies with her on telehealth. And the fun fact about Gloria is she knows 14 languages. No? Dr. Kevin Carter, you know, I think the best thing I could tell you about Dr. Carter is he's a phenomenal physician, but he's probably a better guy. He's the guy you want all your doctors to be. He is very busy. He runs a radiological group, and he's local. And he's spending his very valuable time with us. Fun fact about Dr. Carter is he was the lead role in General Hospital for 15 years. He was Dr. Hunkenstein. Is that correct?
It's true. I like to keep that undercover.
Okay, what's that? John Byrne has an amazing background in healthcare and technology. He is a great guy. Not only, well, same story as Dan. 10 years ago, his dad had early stage dementia. He started a home health care company. And not so ironically, it's called Integrity Home Healthcare. He's also the chairman of Henry Ford Village. Would you like to know the fun fact about John?
I would.
Do you know the Bad Boys? Remember the Detroit Pistons Bad Boys? John was the backup center for the Detroit Piston Bad Boys.
Sure I was.
So thank you for that. So once again, like Susie says, you're here not for me, you're here for them. So I was going to say that what artificial intelligence in healthcare means to me, I was going to share this stupid statistic with you. So if you're familiar with a company called Frost & Sullivan, they do statistics and graphs, and they did a stat, and it said by the year 2025, $150 billion worth of business is going to be done in artificial intelligence in healthcare. I was going to say that, but the truth is it's not about that to me. It's about what Heather said. It's about helping people. It's about the family and what the family thinks. So I'm going to open up to the panel. Dan, what does artificial intelligence in healthcare mean to you?
Thanks, Kevin. I think the best way to describe what we accomplished is through the eyes of our first case. This was a discovery case, and it was the very beginning. It was when we knew we had a company, we knew we had a solution. It was a gentleman living in Atlanta, Georgia, in assisted living. He was an advanced dementia case. He was a football player for Michigan State, and he was unable to speak to people. When he did speak, they were broken words, and the administrators wanted us to test our technology on his dementia cases because he said his cases were accelerating, and he'd be willing to help us by giving us therapies, give us insights as to what we could do with this population. So this gentleman, we started working with him one day a week in a cycle where we visited each facility one day a week. And our care specialist started getting complete words and sentences together. And people kept saying, he's just having a good day. And I'm sure many of you have heard that statement. So, our folks were upset about that, as you would expect. They think they're getting results. People are saying he's just having a good day. The university gave us information, age appropriate, on his football days. The fight song, several things. We put that information into his therapy session, his programs, which are digital therapies. Our care specialist walked in, he stood up and recited the Michigan State fight song word for word. Everyone just was, their jaws dropped, they were just staring, and everyone quit saying, he's just having a good day. So I share that story with you because to be able to accomplish what we do in scale, we had to be able to use technologies to make those breakthroughs. And there's several categories. There's the profile of the person, getting it accurate. I could not afford to scale the company by adding many masters in social work that could sit down with each person and do a profiling of the case. I needed to be able to figure out how to get best practices in that area. The second thing is I needed to be able to pull together therapy components that related to that person very quickly using technology. And that's in the core of what we were using AI for.
You know, that's great. And to me, that story is about the technology wasn't scared, you know, this big imposing he's an offensive lineman with Michigan State, he's 6'5", and inside of him, he was having frustration, and that's just an incredible story. So, oh, by the way, once again, the event is live streaming. I've been told that the camera adds 30 pounds to the moderator. So people at home, I'm very slender. Okay, so we're gonna pass this along because John has an amazing background. I mean, he's got a very diverse background. So I'm gonna ask you the same question, John.
Sure. From my perspective, I feel like I'm living in two extremely different worlds. Principally, I do Medicare certified home health, and we're still largely paper-based. When we get a physician order and we collect the documentation and we appropriately bill it, it generates a blizzard of paperwork. Now, could that be automated? Sure, a lot of it is, but a lot of it's not. In our world, the doctors want the paperwork. When I say, Doc, you can go online and do this, and John, I don't want to learn one more password or have to figure out one more system to navigate. I don't want it. Send me the paperwork and I'll sign it. So what does that mean to me? In our office, we have 4 full-time people just preparing the documentation for signature and then tracking it. If it were automated, we'd get alerts that it was signed, it wasn't signed. We send it out, we sit and wait. Sometimes we have to send it twice. They don't want to sign it. So in that regard, I feel like we're still kind of stuck in the Flintstone era because of all of the work that doctors have to do that's non-clinical related. And it reminds me of 30-something years ago, I was on a committee at Sinai Hospital Detroit, it's long gone. And the committee was called the Quality Assurance and Utilization Review Committee. And I was the only finance representative on this group, and everyone else was a doctor. In the first meeting we went, sorry.
I don't think that was me.
The first meeting we went to, there were stacks of paper, and one was for MPRO, and one was Joint Commission requirements, and one was Medicare requirements, and so on. And our job was to sort of make sense of all that. And one of the doctors said to me, and I'll never forget this, he said, quote, John, I am overwhelmed by things that are underwhelming. So I kind of get that they don't want another password. So we live in that paper base. On another project that I'm working on, it's completely the opposite. It's what I tell Kevin, it's in the Jetsons realm. And this one gets me really excited. I'm working with a group out of MIT called Benefit Science Technology. And it's a spin-off of MIT's Operations Analytics Department. And what they're doing, I think, is a potential game changer. They're looking at claims data to see if there are abilities to predict what's going to happen in the future. The documentation that our physicians sign so that I can bill and collect, that's all stuff that's happened already. Grandma got home care, she fell, her meds changed, that's already happened. What Benefit Science is looking at, BST, is there an ability to look at the claims file to say, if you had these things, do we have a certainty, an 80% certainty, going forward that you will acquire type 2 diabetes? I met them through a friend who's an MBA at MIT, and we looked at some of their initial products, and they're nice products, and they sell to large employers, but I suggested, let's look at what can we do that if there are 10,000 people in the hospital, and they're all 85 years old, and they're admitted under the same DRG, and they're there for the same length of stay, why did 3,000 return to the hospital and the others not return? Or why did those 10,000 wind up in the hospital, and there's another group of 10,000 that didn't under the same medical condition? They love the concept, but they're not clinicians. They have PhDs in applied mathematics and computer science. So they asked if I could line them up with anybody that could provide some clinical expertise, so I did. I'm good friends with Joan Budden of Priority Health. So she's the CEO. I called Joan. I've done some work for them in the past. They're very open to new ideas. So I hooked Joan and her team up with the benefit science people out of MIT. And it took a while. There's a bit of a bureaucracy at Priority. But once we got to the right people, things started to move. So over the last year and a half, they have been analyzing the claims data, specifically initially for type 2 diabetes. And what I didn't know, which is kind of scary, is they can acquire social data from where, Facebook or wherever, I'm not even sure, name specific, marry it to the claims file, and see if there are not 5 things, 8 things, maybe 10 things that if there's yes to these 8 to 10 things, would we then know that there's an 80–85% chance that you're going to have type 2 diabetes? That's the initial question. If they are able to do that, think of how powerful that would be. That would be a tool that we could then give to the doctor in advance and not subsequent to a change in condition. So that's the Jetsons. In my day job, I'm still Fred Flintstone.
Yeah. That's a great story and a great visual too. Flintstones, Jetsons.
It shows you how old I am.
Yeah, the theme song goes straight to my head. I don't know about everybody else. But Dr. Carter, so while we're talking about the patients, if you could share your thoughts on that question.
So I think when I consider artificial intelligence in my clinical practice every day, really Right now, there's very little, and I can tell you as a radiologist, radiologists traditionally are the first adopters to new technology when it comes into healthcare. We were the first specialty to grab computers, to put images on it through a picture archiving system or PACS systems, to send these across the country for teleradiology consults. Even this evening, when I go home 10 o'clock after working my shift tonight, we have a company in Arizona that's taking over to read the emergency room cases that come through. That report will be sent right to the ER. So we're really at the cutting edge. And really, when I look at artificial intelligence, there's really two words to kind of describe where I think the community of radiologists and probably clinicians in general look at this. And the first is opportunity. And I would say opportunity because, you know, as physicians, as radiologists, I mean, we are constantly being squeezed for time, payments, and efficiency. And we're trying to squeeze this as much as possible to get the most out of our physicians, and time is the most precious commodity that we have. So, for example, when I walk in the morning, I may have a list of 45 cases that have been sitting in the queue overnight that need to be looked at. There's no way for me to look at that list and determine which case needs to have my eyes looked at first. I mean, I may have a patient 20 down the list that have a collapsed lung that needs immediate attention, but there's no way for me to know that. And there are some tools being developed by Watson Health, actually through Merge, that's coming out to try to identify in the reading list what cases need the quickest attention to move those to the top. So that way a radiologist can grab that, look at it, and get the report as quickly as possible. The other potential I would see is really, and I was making the statement earlier, is as physicians, I think we probably need to change the term from artificial intelligence to more augmented intelligence. And the reason why it's more comforting, and that'll get to the fear section in a second. But what we're trying to do, and part of everyone's discussing, is really to create homogeneity across the level of care that's delivered. So there's not variability. Dr. Carter delivering this report, his colleague delivering this one, and then if he goes to another health system, they're getting this report. We want to get the same elements that relate to the patient in their specific condition at the same time. So, for example, if I was reading MRI of a patient with a pancreatic tumor, and I mentioned that there's a 2.5 centimeter mass in the head of the pancreas, some type of system in the background that will pull that up to say, okay, did you check the mesenteric artery? Did you check the adjacent vein? Are there lymph nodes? So that way my report has those key elements that will quickly impact the patient. Not only will this make my job more meaningful to the patient, it'll prevent me additional phone calls later on or potential reviews for my colleague's report that didn't include those elements. These are potential opportunities, I think, that will go a long way to make not only our job easier, but in the end, deliver better care to the patients. Switching to the other topic of fear, and I think this is the biggest thing, and this will be the biggest pushback in terms of clinicians adopting this data. Number one, they're already talking, is this technology going to replace my job? I can tell you, I read probably 50 chest x-rays, and I work with a company that's developing the algorithm, deep learning and neural network, to come up and try to potentially take my job. We've been down this path before. We use it every day in mammography, and it's called computerized aided detection. It doesn't work very good. If we were to rely on that only, there'd be so many women that would have unnecessary biopsies. And at the end of the day, we're physicians. I mean, we have to look at this and say, with our clinical judgment, does this make sense? What this computer is saying is abnormal. And at the same time, the fear as a clinician, things have been talked about, well, putting together these deep learning networks and neural networks, well, who owns the data? These patients are giving chest x-rays to be put together by a company, usually private industry, to come up with the formula. Aren't these still patient data and patient information? Don't they have a right to that and how it should be used? So there's a lot of questions, and I think on the medical side, these are things that, at least as physicians, we look at. So at the end of the day, I think there's potential opportunity. We just got to get more opportunities to apply these technologies.
I'll tell you, if you're a technologist or a technology company, or if you really want to know what technology looks like or needs to look like, what Dr. Carter just said should be your verbal white paper. That covered that was fantastic, thank you. That was sensational. Jim, I didn't do a great job, other than saying PTC is a great company, we went to their thing. Maybe if you could spend a very short period of time of telling everybody who PTC is, and then what you see artificial intelligence and how it's affecting you and the folks at PTC.
Certainly, I'd be happy to. PTC is based up in Massachusetts, and PTC has really a history in discrete manufactured products, product lifecycle management, CAD. Okay, so when you think of, in the med device space, let's say a blood analyzer or a pacemaker, infusion pump, something like that, these are the products that med device companies make. Okay, some of them are inside of people, some of them are outside, some of them are on hospital floors and the like, right? So that's our customer base. And it's also automotive, it's Caterpillar, it's large companies. That's the history of PTC. But I would say about 5-6 years ago, our CEO decided that we needed to transform our company because that industry had become rather commoditized, a handful of large competitors competing with each other, right? So what are we going to do? We got to keep ourselves relevant in the world. So he boldly said, we're changing this company. We are going to be the IoT leader. Now, when I say IoT, I mean sourcing the data, making sense of the data, analyzing the data, engaging with the data, whether that be with HoloLens or augmented reality on the side of this, right? Whatever that would be. And so what he did was he went out and did something I think very, very smart. He went out and he found the best of the best companies that did those specific things and brought them together into a platform so people could start their IoT journey with a harmonized platform. That's very important. How many people in here come from technical background, like I was software developer, I was an engineer? Anybody? Raise your hands here. Okay. If you came through the revolution of technology, then what you've seen typically happen is point tool, point tool, point tool, point tool, data all over the place, disconnected, no traceability, and especially in the med device world, traceability is king, right? So the cost of achieving traceability when I have all these tools all over the place is very expensive. It makes audits very hard, very costly, right? So they went through anybody ever heard of the word harmonization? Anybody ever been through a harmonization? What is that? Well, one definition of it is we've got 27 tools. We're going to figure out where the overlaps are. We're going to get ourselves down to a core 7, 8, whatever it is, and we're going to get good, solid traceability. And so that's what you did. And I think smartly, our CEO said, I'm not going to do that. I'm going to be able to start people in a platform that's harmonized so that they don't have that problem. The second thing I wanted to share sort of a personal anecdote on my own behalf and then one on my wife's behalf. My wife is a physical therapist, and she works in healthcare. She's a PT who works for a number of consulting firms, so she goes to assisted living situations and she gives physical therapy. And she's really frustrated because they have to hit productivity numbers. And that forces some therapists, not my wife doesn't do this, but there are some therapists that get 2 or 3 patients operating on equipment, and they're supposed to be paying attention to one, but they can't meet their numbers if they don't do that. Or if my wife has to do evals, it takes so much time to do that, her productivity isn't what it needs to be. So when healthcare becomes a business and productivity needs to be achieved and cost needs to be contained, it can find its resolution in bad ways. But IoT provides some very interesting ways to lower cost and be efficient by leveraging the technology. A brief example, Sysmex is leading in this to create a blood analyzer that can go out into different points of operation, like directly in the doctor's office. So non-skilled clinicians can get results for some tests earlier and not send it out and have them come back in 24 hours, which means a decision could be made faster to perhaps eliminate certain tests that we don't need to do and focus on tests that we should do. Does that make sense? So from my seat here, I'm about practical application of these technologies into existing products, right? That blood analyzer, you know, has been out there for years. Good product. Caterpillar's making great products. Our automotive OEMs are making great products. Those products are there already. But IoT enables us to touch that thing, hear from it, and then it can help everyone who contributes to that product and uses it do a better job. And that was the second insight I wanted to make. The first one was my wife's scenario. But I want to say this is, although my career is in technology, I really, more than anything, think about the people that come to work to do the jobs they do. So think about, if I was to put a product right here, and we could put around it all the people that contribute to it. There are designers, there's service people, there's people training the service people, there are sales and marketing, right? And then if we go out into the ecosystem of people who use this in this industry, there's doctors and clinicians and patients. How do we take this product, and I come from a product kind of standpoint, how do we enhance that product so every single person who's coming to work and designing that, selling that, servicing that, being trained to service it, using it, and maybe even expand the user base to, we give you an app now, so that you, as the patient now, are in the ecosystem around that thing. These are practical ways that we can now make that product better, greater for all those people. I'm a designer and I'm looking at a mashup and I can see all of the whatever products out there across the country and I can see how they're being used. I can see an interesting anomaly here. Well, now I can improve the design because now I know how people are using it. I know what's working, I know what's not working. That's great for the designer. You mentioned about getting an insight to make a decision or prioritize. If I can get the data back and put it in a meaningful way that can tell me where I should pay attention, that's something a lot of us do. We all have a to-do list here today. And so prioritizing, getting to the right things in the right order, if I can connect to it, if I can get the data and get some insights, and if it can tell me to do something, or better yet, even still, if it can do all of that, but it can interface with other systems to get even greater insights to tell me what to do. That's where I see all this. So AI is part of it, but I think of the product being in the center and AI being an absolutely essential part, but these parts all work together so that we get really a total system affecting all the roles positively.
Yeah, and I hear ROI, return on investment. We talked beforehand too, what we were talking about at dinner. ROI. Side note, we just got a note from the Trump presidency. He'd like to thank all 25,000 people who are here today. So thank you for showing. Gloria, so the research university side, what does that mean?
So AI in kind of the research world. So being from SRI, as Kevin mentioned, we developed Siri. I mean, I think that's one of the first things that everybody uses that touches on AI. One of the things we do see is we get to kind of be in the forefront and seeing what is the patient's fear in using some of that. We can develop all of this, but you also have to see what will the patients actually accept. So one of the things we had started developing was kind of an aging studio. And they had like, smart toilets, let's put up speakers around people's homes so we can count how many sneezes they're having, and then we can notify the healthcare professional because, grandpa might be coming down with a cold and needs to be seen. But then you also have to think about the implementation. And that's kind of where this whole clinical research aspect and AI kind of intersect is, are people willing to allow that technology into their home? So we, one, have to show them how effective it is, how much it will help them. And two, they want to know are my things still private? It's kind of like when Alexa first came out, and people started getting toilet paper sent to their home when they didn't really order it. Right? So we have to make sure there's precautions in place because people still want their privacy even with advanced technology. Another thing with AI in clinical research is also just getting the community, to understand the importance of it as well. It's a lot of talking with the doctors, the nurses, as Dr. Carter mentioned, people are concerned, well, am I gonna lose my job? No, we wanna just help you be more effective at your job. And also then from the patient's perspective is maybe they don't have to come in as often because AI is helping to collect this data, pushing that data, organizing it so that their doctors have that. And it, one, either makes for a more effective visit when they do have to come in, or two, notifies the doctor earlier to say, so-and-so does need to come in. There's something we're seeing on the monitors that's saying something's not right, and we need to see that patient. So I think there's multiple aspects to AI that need to be addressed in order to really be able to roll it out to get everybody, both on the consumer side and on the developer side, to really accept that technology.
Yeah, and you bring up a great point, and I don't know the answer to this. What comes first? Is it the technologists? I mean, I'd make the argument that it's the patients with the doctors that should come first, but then where does research and development and university play? And it's a hodgepodge, and I don't know that there's an answer to that, but it sort of makes me think about that stuff. So there's been some great ideas and thoughts shared here, and this is a big question, and anybody can take it, and please just opine. What needs to be done? Where is this going?
I'll leap in a little bit. It always comes down to the economic incentives. I've told the story a million times, and I doubt it's changed. When I was on a hospital board, and hospitals count statistics, and the most important statistic is hospital admissions. That's where they make most of their money. It was early in the fiscal year. They were behind budget in hospital admissions. I'm thinking, well, maybe that's a good thing. Maybe less people needed hospitalization. One of the board members asked of an executive vice president, we're behind in hospital admissions. What are we going to do about it? And the answer was, we're hoping for a bad flu season. Well, that's kind of appalling in a lot of different ways. So until the economic incentives, and they are changing. I mean, we wouldn't be here, we wouldn't be having these conversations if it weren't starting to shift. We're just not there yet. When you've got Jamie Dimon, Warren Buffett, Jeff Bezos, and others saying we're going to start our own healthcare entity because you guys don't know what you're doing, I think that'll accelerate a lot of what we're trying to accomplish. Some of the products that you're discussing, I think, are out there. One of my favorite quotes is, someone asked Bill Gates, what competitor does he fear the most? And he said, 2 guys in a garage. Well, I think there are 2 guys in a garage all over the place. And so the MIT people, again, are looking at not only predicting disease states, but can they develop software that says, you need to go see your doctor because of, or the doctor's notified that John Byrne hasn't seen you in 6 months and we think he should. That's all starting to play out. And I think that value will be there, and then the money will start to shift into the proper categories as opposed to hospital-centered. It'll become ultimately patient-centered, but we're a long way from there yet.
If I could add to that, I think Lori made some really important points, and I'm glad you zeroed in on adoption, because true, business value drives spend and investment and all those things, of course. I'm in sales now. I haven't been in my whole career, but I certainly learned pretty quick that the only way, if someone's got to spend money, right? And money is spent when value is understood. But there are many steps that happen before you get concurrence on value at a senior level. Yeah. And one of them is some of the things Gloria was pointing out, which is you're talking to the person who might use this thing. If they don't believe that this will be valuable to them and accept it, then you're never going to get to the business thing, right? I don't see too many top-down decisions and investments where you don't care whether the people will use it or not. Do you? And a quick example. I was at an event where it was mainly engineers. And this happened yesterday, too. I was up in Saginaw at an OEM talking to a manufacturing operations guy running a cell where people are assembling a product. And we were talking about augmented reality. That is, being able to use an iPad or a HoloLens or something and see the digital over the top of the physical to repair something or assemble something. So in this world it might be, I'm a repair person and I repair large medical equipment and I travel around to all of these places and repair them. Okay, that's my job. That's what my thing is. That person has to believe that this technology is going to make their job better and want to adopt it. How do you do that? And so I was at this event where we showed some of these use cases, and I asked the room, how many people thought that was cool? All the hands went up. How many people are going to go back to their management and say, we need to look into this because this will make our service activities so much faster, so much better, that people are going to love this? All the hands went down. They did not know how to communicate why this was better. So thank goodness someone had taught me, and I said to them, folks, the reason why this technology is worth adopting is because it eliminates a human problem called cognitive distance. When you look at a PDF or a video and then you do something, you lose something when you go back and forth and back and forth and back and forth. And so in a study, they proved that there's a dramatic increase in productivity, faster assemble time, first time quality by applying the technology. So for adoption, there has to be a belief. A person has to come from an I'm in awe to an I'm in belief. This is really going to be good for me. I'm in on this. Then you can take it up and drive it in a business way, and in my world, close a deal.
I'd like to make a comment about this particular topic. Because,
You know what, Dan? Maybe your microphone needs to go a little bit. I'm not sure. Can everybody?
He fixed it.
What would you say? So let me try to project.
Why don't you put your head right here?
Okay, sorry about that. So I'll stay that way and project back. Adoption was for several years, we were looking at the measures based on adoption. And we inherited that from the .com era. And another fact point, the name AI was invented in the 50s. The capability and the logic has been around. It's about being able to compute today to be able to do these things in a cost-effective way. So I'm going to take those 2 points, and I'd like to make a comment about this. My company started from the ground up. We did not start at the hospital or with something that was already functioning and move to the patient. Oh, thank you. I kind of like it because I can honk if I don't want to hear it. So we started from the inside out on what we built. Now, I share this with you because I saw a huge amount of hands go up that are engineers. So what we are dealing with in healthcare more so than other industries, because everything in IoT up to present has been dealing with a machine, not a human, okay? Now we're dealing with humans, and these humans are used to dealing with a healthcare system in a certain way. So we have a culture change, and that's a horrible word. I've earned my early years at IBM, and I went through all the change management training and Six Sigma and all these things that have to do with people. And when I realized that we were in the middle of a culture change to get people to take responsibility for their health, and that meant how do we help them do that better so that we're getting accurate information, we started transforming the way we looked at our profile. And I shared this with Sandy. You notice everything we had under that machine layer for input. Anytime I can eliminate the need for a person to have to enter something, I've not only made their life easier, but I made our lives easier because I've got more accurate data that I can process. And that means I can hand the doctor something that you didn't have to figure out. I can, and let me give you something else to this. Everything that has been done typically has been done by statistical norms. Your norm, each one of you right here, let's just take blood pressure. Your norm is not the same as the person sitting next to you. Therefore, if your norm starts to change, your alerts should be different than you're just meeting the statistical norm, okay? So I share this with you because there's a few points here. If you're innovating, if you're looking at things, if you're looking at solving problems, look from the inside out, and then be aware that we have a history, a behavior, a repetition of looking at things statistically, and so dig into it deeper. So I will tell you that the argument for AI is it's about content. It's about subject matter expertise. Start there and then work out. Does that help?
So I would just make the argument as a clinician, I think and this will probably sound strange for a doc to say this, but it really is about the profitability. If you're going to adapt this, it comes down to how can I get a return on my investment? There's no question about it. We can be humanitarian and say, oh my gosh, we got to do this for the betterment of patients. Yeah. But at the end of the day, we still have to run a business and maintain profit in order to keep providing that care to the patients. And I can tell you, frankly, from the end of the if I was to go to the patient and say, yeah, you could have this great technology, but it's an extra $20, they'll tell no. I mean, that's why I have insurance. I'm not paying for this extra thing. So when it comes to those clinical applications, they don't really understand what's going on in the background in terms of how are they getting the care delivered. They know they're going to X medical facility, and because they have a fancy marketing campaign, it should be a great level of care. Frankly, it could be the doc who is barely board certified who is delivering the care on the other end, but they went because they have a great marketing campaign. So, for what I see when adapting these early artificial intelligence things and new technology is how is it as a physician going to give me a competitive advantage, whether it's my group, so that way we can outmaneuver other radiology groups, other physicians who are vying for contracts, or how can it be a competitive advantage to make us more efficient so that way we can deliver and develop more profit?
So to kind of add to that, you also want to look at your clientele. What are their actual needs? So somebody was telling me about an article that I was talking to Dr. Carter about earlier was in coma patients. So they had developed an AI program that would be able to tell the doctors whether or not, or the chances of whether or not this person would wake up. Like, I think it was something like 9 times out of 10, the doctor actually predicted better than the AI program. So in that field, you can't take away clinical judgment. But perhaps, as Dan's mentioning, it's because of the statistical norms, right? So perhaps if AI was around for much longer, and you had statistical norms for that patient, and then they went into coma, potentially then that AI technology could predict better. But, in the article they said that, a doctor said, nope, I think we're not ready to pull a plug on this patient. The program said, yes, pull it. 2 weeks later, that patient woke up. And then Dr. Carter makes a good point of, well, who do you blame then when that decision is not correct? And I think, that's a big decision. So I think we really have to be careful. Oh, my microphone's supposed to be on. Let's see. Okay. Maybe we'll share this one then. Okay, so do I need to repeat everything? So basically, I'm saying, you know, we have to decide where AI fits best in the medical field. You know, in the coma case, probably not the best until AI's been around long enough to develop new statistical norms that we can then predict more accurately for that patient.
I think just to add one thing real quick, and I think you make a good point, and as a doc, one of our biggest fears is obviously potential poor outcome in taking care of a patient, and I think this is the fear that gets back to. So if I'm putting my faith in a algorithm that's developed by a company for AI, how trustworthy is this? And this comes back to the clinical research, because at the end of the day, when I'm sitting in a courtroom trying to explain my clinical decision making, am I going to be able to sit back and say, oh yeah, the computer told me to do this? And how many juries are going to say, okay, great idea, and at the same time, where does that leave the medical liability to the company that develops this AI algorithm, this deep learning? Is it solely on the doc? There's so many questions that are still unanswered in how they fit together.
That's a fantastic point, and it's actually something that I faced firsthand, okay? So the way we're dealing with that is that what we look for is the pattern of events, sometimes called sentinel events, that give us insights that a person's risk scale is moving. And then that person, before there is an event, is put on a higher observance level. You know, we're alerting for that. So the way we're looking at it is a step at a time. How do I, you know, think about it as taking steps across the stream, and how are you dealing with that so that you're supporting what's going on in patient service. And so I share that with you because that seems to be the acceptable approach for us, and it's been working. We're catching people. We call it catching people before there's a crisis. So you're exactly right. In fact, I'm relieved to hear you say what you did, because it's human, it's personal, and then you got to look at it and say, how do we make technology support us? Yeah. Okay. So I love that.
One point I wanted to make, if I could.
Please.
You know, there's many different use cases to apply technology, right? Some of them are very risky and scary, and some of them are not all that scary, but provide tremendous business value. As an example, one of the companies we work with is Sysmex, and they make blood analyzers. They determined to design a brand new blood analyzer that could go out into thousands and thousands of more settings and could be used by non-skilled people to do very straightforward blood analyzing activity and avoid the 24-hour turnaround. So what did they do there as a company, right? They all of a sudden expanded the universe of users of this technology. They built in safety into it. It interfaces with systems and quality systems to have checks and balances. The unit won't work if it's not supposed to, all those sorts of things. In other words, there's a way to look at a segment of application, and all of a sudden you have a huge number of people that could purchase this device and apply it and use it. Good for you as a business. Good for the patient too, because I can get the results of my blood test in 3 minutes while I'm sitting here with the doctor and not wait 24 hours. I like it, I'm a patient. Doctor likes it. We get some information that we can use right away. So that's an example of something that, with the right controls, is extremely profitable, and it can be good for everyone in the scenario, every one of the roles. So one thing I hope you guys remember today is the word use case, right? There's lots and lots of use cases, right? It's not all, you know, I'm going to make a bad decision with data because the algorithm might not be right. Those are all valuable, but there's lots of use cases that are very straightforward, good ones that can bring a lot of revenue into a company like that and build their business and put more people to work and all that stuff and have a great impact on all the roles.
We were, Kevin and I and Susie, we were at ThingWorks, your big event in Boston. And the company, one thing I liked about PTC is, well, they're a manufacturing company, so they think of everything from manufacturing terms. And And one of the comments I made to them after I absorbed what was going on for a few days is that, hey, we're in the business to manufacture good health. And so that really stuck with me because I was, my father was in plastics, so, like the graduate. And so I spent my early years going to plants with him and watching automation happen, and I was just enamored by Cincinnati Millicron and all these machines. And so I say this because the process of using use cases is a helpful step in all of you thinking about ROI, because you can build a use case that makes sense to your organization, and then you can track the results to it. And when I was at the PTC event, I went to a few breakout sessions, and that's what they were talking about with their folks. So that's something that's really portable as an idea, and thought I'd mention it.
Yeah, and so I'm walking away with two things from that. Number one, Bob Schwartz's favorite saying, it's not the money, it's the money. And then the other thing is Dr. Carter talking and then Dan, talking about the litigation. If you want to know what litigation looks like, the first time I was sued, I had black hair. So, John, you brought up something that, you talked about the big guys coming in. Bezos, Mega World, Health Corp, Apple. My question to the panelists is, what do you think about that? We're some small technologists here. What do you think about, is it a threat for these big Goliath healthcare technologists coming in? What do you think? I'll just leave it open.
To me, they think we don't know what we're doing in the aggregate. I mean, I think people in this room know what but when you look at the large systems, and I can speak pretty thoroughly about this market, change it's at a glacier pace, if it changes at all. And if they're stepping in, they're simply saying, we can do a better job. And we'll wait and see, but I don't doubt them. I wouldn't bet against them. Because if they're going to step into something that's as complicated as this, there must be a level of frustration that's driving it. And they must think that there's costs that they can take out and quality that can be improved, or they wouldn't be bothered. So we'll see.
Anyone else? Thoughts about that?
There's just got to be the experiment. I think that's one of the important steps, is that there has to be some thought that I have to invest something to test these ideas. And one of the things that we had to do, because our company is really a behavioral science company. I have people have kidded me. When I come to a meeting at your office, I feel like I could get a free psychoanalysis. And believe me, I got like 3 PhDs and masters in social work, and our CTO walked out of a meeting one time, and I said, well, how do you, with the content experts, and I said, well, how did it go? And he said, too touchy-feely for me. And so, and I kid Doug about it all the time, but there's a lot of truth to it. So I think that it's really critical to think about investing in something and pull the right team together and understand that you may have to stir that team. Are any of you familiar with the DISC program? Or good, I see a few hands go up. One of the things we did is we put the entire company through the DISC program. And what it does is it kind of gives you what your strength profile is. And the reason why I did it is because, I have these people that are, they could be an amiable, or they could be an analytical, or, they're a driver, and, you got these different personality types, and you need them to work together, and you need to accomplish complex goals. So I use that as a way of helping us help each other understand which corner they came out of in solving a problem. So, if it helps you, I know it helped us. If it helps you, please try some of those aspects in your project.
I would just say, in terms of the big players coming in, I mean, looking back in not that long of a career, but as I said, when PACS and picture archiving systems first came out, RSNA, like probably 2005. I mean, the place was loaded with different vendors, different things, and I've seen this picture before. You know, there's tons of small companies competing for the market space. They come in, bigger companies come in, and it consolidates. Now there's like 7 major vendors that do this. I think this is the same path, and the beauty is with any new technology is that small companies can easily adapt and bring on and adjust to the changing marketplace. You have a huge company, GE, for example, they've kind of lost their way. They can't do that like they used to, or as a small company can. And I think the only way that these big players get into is either buying or consolidating smaller companies to bring in that technology and put together probably a bigger system or a bigger platform.
Anyone else?
Yeah, so I don't think it's necessarily a bad thing. I mean, I think there's a time and a place for it. Like, for example, with SRI developing Siri, we wouldn't have been able to launch Siri into what it is unless we had sold it to Apple, right? So I think in developing the technology, you have to develop it to a point where it's then ready for you to kind of take on that larger partner to globalize it, right? And only you would know whether or not it's ready for that. And it's just like clinical research, you know? There's all these bench-side scientists who are developing products. Well, they don't necessarily have the funding or the marketing team or the business development team to make it a big blockbuster drug. And therefore, they have to take it to an Amgen or a Pfizer to then make it there. So, you know, I think we need those large companies to get involved, but they also need us to kind of develop that ground level.
It's a great point.
I would say, just to add on to that, PTC's business transformation, as I mentioned before, I think our CEO smartly recognized that when a new industry comes up, you have a gazillion small vendors that deal with a niche. Look for AI companies, you'll find a gazillion of them probably, right? It's an important part of the process, but it's not the whole process. And you could easily make the mistake again. I bought 17, 20 tools, and then I harmonize them in 7, 8, 9 years. It's a very expensive thing to do. So I think our CEO smartly realized we were a big player in PLM. We were there with the big boys. We were one of them. He smartly said, we need to go find the best of the best so that our customers don't have to do that. And so that they don't have disparate data all over the place. And they can, remember, we're talking about data all the time in this conversation. The value of the data and not having, you know, I want to have one product in the middle and I want everybody to be able to look at it and get data from it that's meaningful for them. How do you achieve a vision like that without getting disconnected and disparate all over the place? You have no choice. There's a certain number of disciplines in this that you have to serve if you're going to do this as a company. So you want to start off traceable, visible, and that is a challenge. And I think there are some large companies that just maybe waited too long and said, shoot, we got to get into that IoT thing. So they can be dangerous. And the small point companies can be dangerous too. So it's a challenge for sure.
So anybody have any questions? Okay, so I figured we'd have some questions. Maybe it would be a good time to open up for questions. I don't know where Chelsea is, or yeah, we have a question up here. So I think it's live streaming, so they need a mic. Yeah.
My question is to Gloria. I'm very convinced on the forays made with AI and imaging and radiology. But can you give me some example where it has facilitated the research? Give an example where either it improves or cuts down the time of doing an RCT. I don't see much. We do use big data, but we use it conventionally. So can you give me one example? Because theoretically, I find a lot of role, but same thing, people are at comfort zone and they have a pattern, they don't like to change it. And technological people are so busy with their own word that there is not much of interaction. Can you give me some example where basic or clinical research, it has really improved the level of evidence or?
So I think one of the first things that comes to mind in terms of research is if you kind of think about collection of the patient data. A lot of it used to be just straight to paper, and then somebody would then somehow have to get it entered into some kind of database, and then, then the data can get interpreted. Well, now a lot of times you can just do it directly into an iPad. There's no more dual data entry anymore, right? So as you're talking to the patient, you can enter the blood pressure. You're not having to write it down on a source document, and then somebody else is having to enter it into a database, and the database then has to fire its edit checks to make sure, all of that information is going directly in. Another aspect in clinical research is in terms of collecting data from the patients. So now we have things like, heart monitors that people can wear, wrist monitors that monitor sleep. So instead of relying on the patient to accurately fill out a paper diary form, you're getting all of that data now electronically, right? Another thing are portable EKGs now, right? They used to have to come in, you'd have to hook them up with, all of the electrodes, but now you can just hook them up with a single thing. They, some of them are even waterproof, they can shower, and now you can collect EKGs at any time point during the day without interfering with that patient's life.
Any other questions? Okay.
Can you guys hear me? Can everybody hear? All right. I'll just be as loud as I can then. So I heard a lot of resistance, meaning be cautious before you bring this technology to bear. There are areas that will take a long time because of litigation reasons or whatever the reasons are. Are there any areas within healthcare that are really prime right now where this is the right time to bring AI to bear?
So I would say yes, as working in part of a system and looking at delivering high-value care to patients. I think, again, it comes back to the money. So if you chase the money and see where the return is, part of it is now patient experience, patient engagement. Hospital systems are judged by how patients view them. CMS is looking at this. They're looking at trying to reimburse hospitals and health systems based upon that. One of the things that I can say is some of the hospitals that I work with, they struggle with is, for example, nurses coming in to take care of the patients on an hourly basis, rounding. I mean, nurses are busy. They have patients. This patient's calling. This one might fall. So putting together some predictive technology that could say that, Mrs. Jones every 20 minutes needs to be checked on to make sure she's in an appropriate pain level, or that she needs to go to the bathroom every hour, to remind the clinical staff that, yes, let's get back there. This would be an instant turn on to say, yeah, patient feels like they're getting cared for, they're getting the appropriate attention, and you know what? X hospital, they made me feel awesome. I'm giving them 10 out of 10 on their patient satisfaction survey. This is the area that everyone is struggling with. It's not one health system, it's not one hospital. Everyone is struggling with how do we deliver that high level of care consistently, constantly, to every patient every time. And it gets back to that consistent product that we're trying to deliver.
I think one of the simplest AI things that we're seeing now is just the whole telehealth programs. Use a Blue Cross Blue Shield, Aetna, they're all starting to go to this teledoc. Even the University of Michigan Health System is starting to push out a telehealth. Just put in your concerns and the doctor will call you. And they're seeing that, one, they can get reimbursed for that, and two, for some of these simple things, you don't need to physically see the patient. You can address these patients' concerns through a telehealth visit, and that makes the doctor that much more accessible to the patients.
There's a fascinating kind of direction of credit that we discovered in the last 45 days. We caught a person before she crashed. She was a hypertension patient on Medicaid and had 2 visits a month. And the caseworker didn't pick up on anything, and of course, very typical, she kept saying, I'm okay. But she had self-reported, and it came through our system that she had self-reported 3 times in a row that she was not doing well. And so that hit our notification capability, and a manager contacted her. Now, they dealt with that person, and they got her blood pressure under control. They got her, there were a couple other things that were going on that were social determinants that were accelerating her condition. She was getting pushed out of her home. It was under rent subsidy, and they were able to fix that. But the key point is that she is like in love with the case manager. She just talks about him such a glowing way all the time. You're the one who cared about me. You called me and then got me into the doctor. And I like that. I don't need to be the one saying, oh, your system did this. We want the care team to win. So, and I find that is a kind of a neat thing that can happen as a result of improving and thinking of it as a team effort.
And circle back to Heather, it's not about me, it's not about the technology, it's not about you, it's about the family, what it does for the patient. So, and if the microphone doesn't work, I can repeat the question so everybody can hear.
It's not actually a question, it's just a comment. You know, in healthcare, a large amount of energy and effort goes into managing data and managing how you get claims. Okay, so that's a good example that is not going to affect the patient's life, but it's going to affect all of their businesses. You know, anybody that's attached to the healthcare industry, you know, getting the money in a quicker, more efficient way that requires less of the physician's time, less administration. That's a good example of how AI can be used right now. It has to come with the caveat that it's got to be HIPAA compliant, just like video streaming services. So it's not, if the time is right for it, it just, you have to be able to manage some of the legal aspects that HIPAA and the Affordable Care Act and these other types of things really mandate on you. But there's a lot of applications that are not specific to clinical that can be can use AI right now, and that is being developed right now.
You know, another right now one to think about is, again, I come from a product side, right? There are a lot of products out there in the med device area that a patient might not directly interact with, but are used in diagnosing them and so forth, right? So if we can connect to those products and we can get some insights from them, today we can start training the service person using technology like augmented reality, right? To walk up to that thing and fix it faster. They walk up to this thing that says, this is the part that needs to be fixed. They do this, it shows them exactly how to do it. They order a part, it connects in with an ordering system, they close a ticket. So we've taken this use case, and what value is that to the patient? The machine is always up and operational. That drives profit for the company that owns the machine. That's good for the patient because it's always up, right? And if it interacts with other systems, if I'm a person who's being trained to do this and I go out and I service the machine, I do it faster, I do it better, the compliance checks are there, right? You could take, I mentioned use case before. The use case for here for a service person might today be, I got a laptop, I got 3 systems I'm logging into and I'm doing this whole procedure and I go in not knowing anything. But if I walk in there and before I even get there, I can see what's up with that machine, what repair procedure I'm going to have to do, and I can walk through the steps to do it. That's a today thing. That's something that could be up and operational very quick, very practical stuff that has a great business impact, and it's great for patients, great for doctors. That's a today one that I've got a list of companies here that are all doing that kind of stuff.
Thank you. I think we have and I can interpret it if
well,
so the video streaming can.
My question is, you know, you've really made some really very important points.
on multiple levels. And just to kind of connect the dots on some of those issues, because you talked about how you have new technologies, but then are they going to be practical in terms of profitable for the practice to be able to implement those effectively? And how does that turn around in terms of if it is improving patient outcomes, then does it merit the use of that technology? And how do we connect the dots between, like you said, that CMS is doing more research into really how improving patient outcomes is driving profit, should be, you know, one of the drivers to profitability, and using new technology and having the physician having more direct input into what CPT codes are billable for the use of these technologies, and how the driving force of reporting and clinical decision support is being used to determine, you know, when patients are in need of various services or tests.
So it's a great question. It really is. You've talked about a lot of things, and this is for the video audience. How do you connect all the dots? It circles back to how people get paid, saving doctors time and money. Then he finished it up with saying, Kevin, you did a great job. So thank you. Thank you. No, go, so please. If you could take that, it's a great question.
Wish I had an answer.
So I think it's a challenging question, and I would say, yeah, so the first part was that, yeah, this technology or potential technology could have significant impact on patients' clinical outcomes, but how do you implement that if the profit's not there potentially? And that's the challenge. And I mean, at the end of the day, if it truly is, it will come back to working with our research colleagues to demonstrate a clear benefit, and then you can take that then to the payers and say that this technology does make a difference. But you know, on the practical side, yeah, there are technologies that are potentially out there that could make a significant impact to patient clinical care, but frankly, they can't be implemented because, you know, it doesn't make financial sense, and that may be challenging or hard to I guess, come to terms with, but that's the truth, unfortunately.
That's the multi-billion-dollar question. If you have the answer to that, that's a tough one to answer. We all want the answer to that one. So, but it's a great question.
There's an excitement and a coolness about technology, but I think there always has to be let's do a business case evaluation for this. It's very important to do that. When you choose different use cases, it's really important to break it down, look at how it's really affecting people, and see if there's a business value for it. I've been in many engagements where we did that step up front and determined very quickly that this isn't a good use case. It's not going to be valuable enough. There's something else that we should do. And we went and found something else that proved its value. So you don't have to go develop the whole scenario and put it in people's hands to get to know that. There should be business value research done as you're encountering use cases. And we talked about adoption as an important thing too. But business value is, at the end of the day, you're not going to go forward and make changes if people don't pay for it. And you have to justify the spend. And that means that you're looking for places to apply technology and use cases, but you need a good business case for it. That's fundamentals. If you skip that step, you'll do all the technology work and present, and they'll say, very nice, and not do anything.
So this has just been, and Susie, you're right. They're here to listen to them, not me. You're right. This was fantastic. I'd be remiss not to thank the two key people that made this happen. Chelsea Schutz, thank you. Dom. Dom is the new face, the new voice, the new words of Medical Main Street. You want to be involved in this amazing organization. He gets the support of Irene and Ryan, and this is just a great thing to be involved in. I encourage that you talk to Dom. So thank you. I know, to spend your time on anything, to leave the office, it's a big deal. So hopefully, I really learned a ton. Some things were just amazing to me. So thank you all for coming. Thank you very much. that?